evening, dear professors, dear colleagues. I'm going to explain a rare case of mixed pathology with IgA deposition and IgG deposition, mix or overlap between membranous and IgA nephropathy. A 39 years old male patient named Mr. T presented to our nephrology unit on 21 of May this year with one complaint of frothy urine. The patient was diagnosed as ulcerative colitis and primary sclerosing cholangitis since more than 25 years. He has a family history also of having a sibling who was previously diagnosed as FMF and paternal history of cancer colon. The patient was followed up by gastroenterologist and was prescribed the following drugs: mesalamine, azathioprine, prednisone, esomeprazole, orsorfalk, folic acid, and calcium supplementation. The patient on examination was fully conscious, of average build, no special decubitus, gait, or complexion. The patient vitals were normal. His examination was also normal except for mild bilateral soft pitting edema up to mid-calf. Investigations was done. His hemoglobin was 14 gram. Total leukocytic count was normal with normal differential and with normal platelet count. Urine analysis showed protein 3+, passed from 8 to 10 per high power field, RBCs from 2 to 4, and few hyaline casts. His creatinine on admission was normal. Urea was 39. Immunology or immune panel, negative virology, negative ANA, anti-double stranded, C3, C4. Urinary albumin creatinine was about 2.9 gram per day. He has also elevated liver enzymes, elevated cholestatic panel as gamma GT and alkaline phosphatase. The patient was previously, as I mentioned before, was diagnosed as ulcerative colitis and had multiple colonoscopies and biopsies confirming that diagnosis, with subsequent MRCPs and ARCPs undertaken between 2014 to 2022, all confirming primary sclerosing cholangitis, also interfering with the intrahepatic biliary structure with successful attempts. Liver biopsy was also done on 2022 with histopathology showing primary sclerosing cholangitis overlapping with autoimmune hepatitis and vanishing bile duct syndrome. Patient's serology for autoimmune hepatitis, ASMA, LKM, antimitochondrial antibody, anti-SLA, all were negative. IgG level was mildly elevated and was negative for calprotectin. DEXA score showed minus 2.7 standard deviation. Upper GI endoscope also showed mild gastroesophageal reflux disease. The patients underwent renal biopsy for 2 core, showed 17 glomeruli. One of them was globally sclerotic. 13 out of 16 viable glomeruli showed prominent GBM. Diffuse mild to focally moderate interstitial fibrosis and tubular atrophy, mild and focal moderate ATN. Immune histochemistry was done, showed heavy deposition of IgA in the mesangium, heavy deposition of IgG in the mesangium and in subepithelial space. And that was confirmed in electron microscopy, and this will be discussed by Dr. Maram. We contacted gastroenterology unit for modifying. تمام.
البيوبسي الدكتوره منال هتقاطع.
Assalamu alaikum. The next presentation, please. Okay. Okay, as regard the pathologic findings of our first case, microscopic examination of serial sections from the submitted renal core biopsy stained by HME, PAS, trichrome, and congruent stains revealed two corticomedullary renal tissue cores featuring 17 glomeruli. One of them is globally sclerotic, and 13 out of the viable 16 glomeruli feature prominent rigid GBM with segmental mesangial matrix expansion in 3 of them. Again, here we have these prominent glomerular basal membranes, mesangial proliferation, segmental mesangial expansion. As regards tubulointerstitial compartment, it revealed the diffuse mild to focally moderate interstitial fibrosis and tubular atrophy with no inflammation, mild to focally moderate acute tubular necrosis. Congruent stain negative. Immunohistochemical staining revealed intense positivity for both IgG and IgA, mainly in the mesangial compartment and with few scattered granular membranous positivity. IgM negative, C3 of moderate intensity. As regards ultrastructural examination, it revealed mesangial electron-dense deposits with scattered intramembranous electron-dense deposits. Again, here we have mesangial electron-dense deposits, intramembranous electron-dense deposits, mesangial and intramembranous. The same. So the final diagnosis, the combined morphological, immunohistochemical, and ultrastructural findings are diagnostic of codominant IgA nephropathy with membranous pattern of nephropathy with no crescents, mild to focally moderate interstitial fibrosis and tubular atrophy, mild to focally moderate ATM. As regards renal involvement in IBD patients, it has many pictures and comes on the top glomerulonephritis, especially IgA nephropathy. Here we have a recent study published in JASN. It found a significant association between IBD and IgA nephropathy and an increased risk for end-stage renal disease in IgA nephropathy with IBD patients. Here we have a question: how IgA nephropathy presented with membranous pattern and scattered intramembranous electron-dense deposits. Here we have a recent study. This study concluded that the concurrence of IgA nephropathy and membranous nephropathy displays similar clinical features to membranous nephropathy patients and milder pathological lesions than IgA nephropathy. So these concurrence have similar levels of galactose deficient serum level of IgA1 to those of the IgA nephropathy patients and lower proportions of anti-PLAR or anti-phospholipase E2 receptor than membranous patients. So our case presented by very mild features, pathologic features. We had mesangial hypercellularity in less than 15% of the glomeruli, 50% of the glomeruli with moderate tubular atrophy with no crescents. And here we have a more recent study for this concurrence of IgA nephropathy and membranous nephropathy. And in this concurrent group of IgA nephropathy and membranous nephropathy patients, this study revealed the presence of moderate to intense positivity for both IgA and IgG, with moderate intensity for C3. And as regards Oxford classification of IgA nephropathy, the majority of cases had no presence. By ultrastructure, in 100% of patients had both intramembranous and mesangial electron-dense deposits. Thank you.
Dr. Maram, please, I have a question. In my opinion, this case could be diagnosed as IgA only without membranous glomerulopathy, because the deposit at ultrastructure for the membranous should be subepithelial and not intramembranous. And the intramembranous in this case is scant or
yes, they are less frequent. I told yes, they are less frequent, but they are present.
You mean this is C3 associated but not membranous? What's
C3 of moderate intensity, but IgG was of intense positivity. Yes, okay. It was of intense positivity. Both are equally of intense positivity.
Okay. Thank you, Dr.
طب معلش نعم. لا هي الكومنت على الحته بتاعت intra membranous. What I could understand that sometimes in membranous nephropathy, after some time, the subepithelial deposits are insinuated or
Yes.
included,
And become
so that it
intramembranous.
becomes intramembranous.
Yes. Yes.
That's
This is
what
the
I
IBD.
understand.
Yes. It
لا
starts as
لا دبل
subepithelial.
كونتور دي معناها انها member primitive. It is not member.
No, it starts as subepithelial and become insinuated
Yes,
inside the
that is
membrane
what I
and become
understand. So
intramembranous.
so
Then it fades.
being intramembranous is not against membranous nephropathy.
Yes. Thank you.
Good evening. I will continue what has been said by our colleague and give a brief overview about IBD-associated nephropathy. I will give a short overview about IBD and then the extra-intestinal manifestations of IBD and then IBD-associated nephropathy and then different clinical presentations. IBD overview. Of course, it's a chronic inflammation of the gastrointestinal tract with two most common types, Crohn's disease and ulcerative colitis, mediated by abnormal T cell function in a genetically susceptible patient. And the two diseases are characterized by different T cell response with Crohn's disease, mainly by T helper, mediated by T helper 1 and ulcerative colitis by T helper 2, secreting different interleukins and different inflammatory process, and this later on will be found that they have different treatment according to the interleukin secrete. The exact and standard manifestations of IBD, actually they represent about 6 to 47% of IBD patients, commonly the skin, the ocular manifestation, the arthritis, and also there is a hepatobiliary complication which are common. The majority of extraintestinal manifestations, they accompany the underlying intestinal disease. Speaking about the IBD-associated nephropathy, renal and urinary involvement has been reported to occur in 4 to 23% of IBD patients. Parenchymal renal disease is actually rare, but has been well documented in the worldwide literature. It has been documented in several case reports reporting IgA, membranous, antiglomerular basement membrane, and even vasculitis. What are the link between IBD and the associated nephropathy? It might be a systemic reactive manifestation directly related to intestinal inflammation and disease activity, or either an autoimmune disease independent of IBD, or deposition of circulating immune complex or in situ formation, increasing the risk of GN and perhaps tubulointerstitial nephritis, or either a manifestation of secondary to the metabolic and anatomic derangements. Susceptible patients are those patients with a greater duration of the disease, who have a larger resection of their small bowel, who have recurrent nephrolithiasis, and those who have a number of interventions due to renal stones. Clinical presentations. Speaking about glomerulopathy, we have IgA nephropathy as the most common presentation. Amyloidosis is another presentation. Minimal change disease, even membranous nephropathy, minimal change disease are other presentations. Speaking about IgA nephropathy, this paper published in 2014 in CJSN, the histological spectrum of kidney biopsy in patients with IBD. This was a large retrospective study conducted from 2001 to 2012, including 33,000 kidney biopsies, and out of 33,000 kidney biopsies, there was an 83 IBD patient, and out of the 83 IBD patient, 25% had IgA nephropathy, and this percentage was much greater than the other non-IBD kidney biopsy, so it is quite common. And as we all know, the pathology of IgA nephropathy by immunofluorescence, there is mesangial deposits that are either dominant or co-dominant with other immunoglobulins, usually with C3 present in 90% of the cases, IgG in 50%, and even sometimes IgM. And there is mesangial expansion by light microscopy and electron dulce deposit in the mesangium. Speaking about the pathogenesis, we all know that it starts with an aberrant IgA1 with galactose deficiency, the abnormal glycosylation occurs in the hinge region of the antibody immunoglobulin, and against this immunoglobulin there is usually an IgG or IgA autoantibody leading to the formation of immune complex which is deposited in the mesenchyme. Why do IBD and IgA nephropathy co-occur? It starts at the mucosal level where there is B cell priming due to the presence of B cells in accompanying the mucosal associated lymphoid tissue, where there is release of the apparently glycosylated IgA1 and formation of autoantibody in a genetically susceptible individual, leading to the formation of immune complex and mesangial deposition. So in IBD patients, there is increased small intestinal mucosal permeability, and there is loss of antigenic exclusion and increased risk of autoantibody formation. There is chronic immune stimulation. There is dysregulated IgA production and transport. And we have to say that there is genetic susceptibility in the HLA DR1 predispose the patient to IBD and IgA nephropathy. As Dr. Maram have just said, predicting the risk of progression, we have the MEST C-score. It is histological finding used to predict renal outcome independent of proteinuria, eGFR, and blood pressure. M1, S1, and T1 and T2 associated with poor renal outcome. The endocapillary hypercirculatory and crescent predict response to treatment, and C2 increase the risk of poor renal outcome. Also, we have, after that, the new international risk prediction tool, which predicts a 50% decline in eGFR or development of end-stage kidney disease up to 70% post-biopsy, including in the risk assessment, the MEST score, the age, the eGFR, the systolic blood pressure. فاضل 2 slides. أو أكتر. eGFR, systolic blood pressure, diastolic blood pressure, and RAS blockade. Management of IgA nephropathy, we have to think about the KDIGO guideline 2021, including first diagnose IgA dominant glomerulonephritis, and we have to exclude secondary causes, then do the score, and then the international prediction tool, and enroll the patient in the disease registry and start the optimized supportive care. I have started the supportive care. As we all know, the ACE and ARBs target the blood pressure, diet restriction for 3 months, and then re-evaluate the patient for the presence of proteinuria. If it is still more than 1 gram, according to the estimated GFR of the patient, if he is less than 30 milliliter per minute, consider optimizing the supportive care. If he is more than 30 milliliter per minute, we can consider steroids, but according to the risk benefit. IBD, is it common with membranous nephropathy? Actually, it is a rare correlation between the two. conclude. كنت عاوز بس الايديا دي واقول الكونكلوجن. ممكن نفتح بس 1 minute كمان بس. انا بس هقول الايديا ان احنا الاسوشيشن ما بين الاي بي دي والممبرز از فيري رير، بس في كيس ريبورت اتكلمت عن فكره ان في اوفرلاب سندروم ما بين البيشنت اللي عنده لونج ستاندينج ألسرتيف كولايتس وجاله بعد كده برايمري سكلوزنج برونجايتس واوتو اميون هيباتايتس، وده اكشولي بريزنت في البيشنت بتاعنا كان عنده ال3 اوتو اميون ديزيز دول، ولقوا ليتر اون ان هو ديفلوبد ممبرنس نيفروباثي. فدي كيس ريبورت مش ذات كومن، بس في اسوسيشن بيقولوا ان ده ريليتد للاوتو اميونيتي، ان هو هي از لايبل ان هو يتديفلوب جي ان، وكانت التايب اوف جي ان في الكيس دي which is quite similar to our patient كان membranous nephropathy. طيب other disease amyloidosis, as we all know, is one of the commonest cause presenting with proteinuria and nephrotic syndrome. Also tubular interstitial nephritis is common related to the drugs and can be related to the activity without the drug cause. And how to monitor finally the patient with the kidney IBD patient, we have to do the renal function, and according to the renal function and eGFR, we have to see if the patient have a declining GFR or the patient have low urinary pH and liable for development of nephrolithiasis, one of the common complications. And if the patient develop nephrolithiasis, so we will do an ultrasound. If the patient has reduced estimated GFR, we have to see if he have either proteinuria alone or proteinuria and hematuria or tubular proteinuria or enzymuria. So we have 3 entities, either tubular interstitial nephritis, GN and even amyloidosis if proteinuria is dominant. So we have to do a renal biopsy, and we might change the treatment plan of the patient. Thank you.